I tried to keep it relatively brief, and so 10 minutes on back pain is really pretty quick, and I'm not going to be able to go into a ton of detail. And those of you that are physical therapists, I'm sure, could understand that, and actually everyone here can understand that. So I'm going to try to cover some, quick basic things, my thought processes when dealing with the patient with low back pain. The number one question is, why do we need to worry about this? And the answer is, it's incredibly common. 85% of us at some point in our life will develop low back pain. For most of us, it's a quick transition back to normal. 2 to 4 weeks, we're better again. It can be mild to severe, but anyone who's had back pain that's been bad, that's lasted like I have, knows that it can be really disabling. And so it's important to be able to get yourself feeling better as fast as you can and prevent recurrences. The real question is, why do we have it? And this is sort of a great slide. Is that, as we developed, we started working in the fields and we did physical activity. And over the years, we now sit at a desk all the time. And not only do we sit at a desk, we slump over. And I constantly find myself explaining to patients how they need to sit while I'm slumped over the computer doing things. So proper positioning is really important. It's a huge piece of the puzzle. There are other risk factors, genetics. My brother and I both had disc herniations. We had the same 2 disc herniations. He is 6 foot. He was 260 at the time. I'm obviously not 6 foot, and less than 260. He never played sports. I always played sports. And so the answer is, there's a genetic predisposition to having, back problems. Age, younger athletes, younger people generally hurt themselves through athletics. As we get older, there's a wear and tear problem, but that doesn't hold. I've had a 93-year-old gentleman who complained that he had difficulty playing squash because of his back. And, he could only play 3 times a week. And so the answer really is that, that's not a hard and fast rule. Smoking causes or contributes to back problems because you end up constricting your blood vessels, you heal less well. And so smoking is another factor. Dr. Sarno has made a living out of talking about how stress and psychological issues affect your back. And they do, absolutely. If you hold yourself tight, you're going to end up having back problems. It's not the only problem, but it certainly comes into play. Bending and twisting injuries. And then there's an unknown factor, an X factor, that we don't know. You can have 2 people who do the same thing, have the same risk factors, and one will have a problem and one won't. The anatomy of the lumbar spine, there are 5 lumbar vertebrae, ironically labeled 1 to 5. So starting 1 at the top and then 5 to the bottom. There are discs in between. They are shock absorbers. We label them as the bones in between. So the L4-5 disc is between L4 and L5. There is a center space where the nerves run in the middle of the spine. And then the openings right here, these sort of openings on the side where the nerves come out. And then a tailbone, which is the sacrum. This is sort of an angular view. These are facet joints, also known as Zygapophysial joints, but I call them facet joints because that's a really big word and no one knows what I'm talking about when I say Zygapophysial joint. Well, Tamar and Chris do, but the rest of us don't. And that's this little tripod joint in the back of the spine. The spine is a tripod, big bone with a disc in the front, 2 little joints in the back. They provide stability, they prevent the bone from translating forward, and they also prevent rotational injuries. So they're very important, especially for rotational-based sports. So why is it hard to diagnose back problems? And the answer is there's a lot of stuff that comes into play, and it's all really close together. There are the bones, which are the vertebrae, which can have fractures, the nerves, which we can get sciatica, muscles, strains, disc problems, disc herniations, degenerative disc disease, joint problems, the sacroiliac joint, which is my favorite diagnosis because it's the great masquerader, and then the zygapophysial joints, and then ligaments in the spine itself. So instead of looking like those neat little models I showed you before, it really looks like this. And this doesn't even show all the muscles that are involved. And then the sacroiliac joint, which I allude to, is this joint here where the sacrum and the pelvis come together. And it's actually surrounded by the strongest ligament in the body. And it's controversial as how much motion there is, but I've had SI joint problems, and it can be as bad as any other back problem that's there. Golf in particular is one of those sports that sets you up for back problems. In fact, when the Titleist Performance Institute did a review, they found that 28% of golfers deal with low back pain after every round. So if you can imagine that almost 30% of people have back problems after every round, the people who play will have some back pain, and a majority of people at some point will have back pain associated with golf. And one of the reasons for that is, as the swing has evolved over time, it has gone from a classic swing, which is on the right, where the spine is in neutral, to a more modern swing, which results in a reverse C or hyperextension. So you really lean on the back of your spine with rotational motions. And that's going to put you at risk for lots of problems. And exactly what I just said, which is the newer modern golf swing will put pressure on those facet joints and also put you at risk for disc problems. Another issue is because when you're on the golf course, you're walking on uneven surfaces. You can get your foot caught in a gopher hole. You could just move on uneven surfaces. You can aggravate those SI joints. You could aggravate your facet joints. How do I decide what the problem is coming from? That's simple. It's history and physical exam. 90% of what I need to know comes from just talking to patients. That's the most important point. All radiologic studies we use just to confirm what we think already. So then how do I treat people? Well, the answer is you have to know what you're treating first before you decide what you're going to do. And the reality is most people get better if I do nothing, which is great for me because most people get better if I do nothing. And my goal is just to speed along recovery and prevent them from having a recurrence. So keep in mind that everything I'm talking about, my real goal is to not have them come back and see me again. So anyone who has seen me knows there are 5 ways to treat any problem. I have this speech for every patient. You can do nothing. You can do physical therapy, medicines, injections, and surgery. I'm going to leave the surgery out of this being a non-surgeon, but obviously there's a role and a place for surgery for mechanical problems, but for most problems, they're non-surgical. So you can do nothing. And if you do nothing, that's a choice, but obviously people don't come in to see me and do nothing. And so I kind of eliminate that as a choice. Physical therapy, which is what, as far as I know, you guys do as physical therapists. It's all this heavy weight. The long-term solution, and I remind all of my patients, is the exercise. Everything that the physical therapists teach them to do is the most important thing. It's all about getting yourself loose, getting yourself strong. So even though I'm not going to go and cover what the physical therapy exercises are, it's the single most important part of this talk is make sure the patients actually do the therapy, do their home exercises. Everything else is just a temporary fix in the meantime. Medicines, take them until further testing shows they aren't really effective. And that's kind of what happens, which is everything that we've used in the past. Now, I used to say anti-inflammatories were, a no-brainer. Now I have a talk with every patient about the FDA saying there's a risk of heart attack and stroke, and doesn't matter if they're, 60 or 21. I have that talk because I have a family of lawyers, so I know I have to do that. But we certainly use medicines. We use anti-inflammatory medicines, muscle relaxants. We're trying to get you better faster. Injections, which is one of my favorite things. I love giving shots. I hate getting shots. And so I try to be nice when I give shots, but I reserve that for people who have failed other problems or are severe and can't function. So again, the goal is just to decrease the pain. No shot improves your function. It doesn't heal. It doesn't make you heal better. It just allows you to function better and do your exercise. So I explained that you don't have to do a shot, but it can help you do better and do your physical therapy better, and then that gets you better. There are non-guided shots, which are just blind shots, like trigger points, where we feel the knot in the muscle and inject with a little lidocaine, break up that spasm. Those are those knots that we all have, but when they cause pain, we can inject them. And then the guided shots. You can either use ultrasound or fluoroscopy. For the spine shots, we use fluoroscopy exclusively because it's still the gold standard of care. There are epidural shots for sciatica, which is steroid injections, again, for disc problems, stenosis, and then facet or sacroiliac joint injections, which are also steroid injections, but obviously into those joints. So this is a picture for an epidural injection. This is what we call a transforaminal injection, which is from the side, trying to bathe the nerves as they enter the spine. There are 2 needles here, and you can see this black stuff here is CAT scan contrast flowing up and around the nerve roots where we want it to be. The sacroiliac joint is this tear-shaped joint right there between the sacrum and the pelvis, and there's the needle there. And then the facet joint is, we go in on an angle, and there's a needle into the facet joint itself. One thing about, before I jump into my rules of thumb, that I forget, I gave Sue the slides early, and I came up, realized that I left something out, which is there are 2 topics of conversation about shots that have come out recently. I've had a lot of patients ask questions. One is PRP, which has been discussed for ligaments in the spine. And The most recent literature is still in the very developmental stage, and there's some evidence that looks like it may be helpful. We're still trying to figure out who it helps, and what the protocol is. And I have a rule, which is I don't want to be the first kid on a block with a new toy in the spine, and so we're not there yet. But that may be the future. The future may be biologics in the spine, but currently we don't use them, and I don't recommend that someone goes and gets that. And the other question is, with steroids in the spine, the whole controversy of how bad it is for your bones. And the reality is, I think it's much like anti-inflammatory medicines, which is way back when I trained in my fellowship, we gave out anti-inflammatories like it was water, right? And we never thought about it. And we checked your blood to make sure your kidneys or liver wasn't affected, and that was it. And then the Celebrex and Vioxx controversy happened. And now we look back and say, every anti-inflammatory has a risk. Everyone has a risk. I think every steroid injection has a risk. Every steroid injection in your knee or your shoulder or wherever carries a risk of systemic effects and bone breakdown. So less is better, right? You want to do less, but that doesn't mean there's no place. It just means try the other things first. So the lessons I always tell my patients are, listen to that voice in your head. If you think you're doing something that you shouldn't, stop. It's the number one important thing. I get patients who push past pain, and it's the worst thing they can do. Ache is okay, pain is bad. So you really have to listen to your body. Keep your body strong and loose. That's going to prevent problems down the line. Again, all those exercises, all that core stuff. Medicines and injections are just there to help you decrease your pain so you can exercise better. And then the other point is proper mechanics can prevent problems. But on the other hand, we get patients who sometimes go and see their pro, and their pro dramatically changes their swing. And all of a sudden, problems that weren't a problem before become a big deal. Their hip arthritis becomes a big deal. Their degenerative disc disease becomes a big deal. So little changes in your swing, in your mechanics can be helpful. Gross changes all at once really set you up for trouble. And so just keep that in mind when you're looking to change your mechanics. That's it. Thank you very much.